we have a small group. We were just kind of joking about how in December, I think everything kind of wanes for most people. But as a reminder, this is being recorded. So a lot of these roundtables are available on the Learning Center at mopa.org. So we're going to record this. We're going to go ahead and go through the discussion today, and then individuals can watch it within a more convenient time for them. As a reminder, it's a discussion, not a seminar. So jump in, especially with a small group. We can have a good discussion today. You turn your audio and video on and off as you see fit. If it gets loud, we may mute you. Just unmute yourself. You can also submit things via the chat. So it's my pleasure to kick off today and just introduce the panelists. I'll start with Michaela, and then you can tag somebody, Michaela.
All right, so Michaela Muehlbach, I oversee outpatient psychological services at Compass Health Network. I am a former BHC myself, and integrated care is a huge passion. So every month, even though it seems like these come faster and faster every month, it's such a wonderful opportunity, and we're so excited to share space with everybody in here. And I'll pick Robin.
Thank you, Michaela. Hi, I'm Dr. Robin Lute. As Michaela mentioned, I was also a former BHC. That was my first out of graduate school job, official job at an FQHC. And then I went into teaching and training integrated care for quite some time. And now I'm back at Compass Health as a psychologist, a provider.
Am I up?
I mean, tag, sorry, Kristen.
I am Kristen Thompson. I'm the System Director for Pediatric Integration at Burrell and help develop integration programs in the operations of those. I'm also a former BHC and have a passion for integration, which is, like the others, why I'm involved in this every month.
And I'm Chelsea Gillum. I am the System Director of Adult Integration at Burrell Behavioral Health, so integrating primary care, internal spaces, college campuses, and emergency departments. Also former BHC who absolutely feels passionate about that work, especially during this time, being in a pandemic. So we're going to talk about today procedural anxiety. I want to start by just clarifying that because we're going to use it in a pretty flexible manner today. I think there's a breadth of things that we're going to discuss. But when we talk about procedural anxiety, we're really talking about when patient feels anxiety in the anticipation of or during a procedure. And that could be screening, diagnosis, or during treatment itself. And as we know, if that's not treated, there can be negative health consequences. The most obvious would be that individuals just won't get the treatment that they need, even basic treatment, whether that be their blood draws or a flu shot or a pap smear or anything like that. A lot of the wellness stuff just kind of falls off the radar when someone has anxiety and if it can be ignored. And so we know that has a lot of negative health consequences. So this is a huge area where we can be of assistance, but it's not one of those areas that kind of is something that we talk about a lot. So we thought it would be important to have a full roundtable discussion on it. So I guess my first question to panelists and to the whole group is, where have you experienced this need in your clinics where you've either supervised or where you've worked yourself? Can you give some examples of where you've experienced that, where it comes up for you?
Something that came to my mind immediately was at Compass, we have psychiatrists and we also have primary care teams, but most of our clinics have psychiatry teams and they're nurses that are supportive to those processes. And inevitably the littles, for sure, when the kids come in, you know, it was like you always knew when there was a child that was going to be getting a blood draw or yeah, thanks. Robin always has our back of the shout outs. But like you always knew. And so even though like my role, and so this is where I think that like when we talk about role definition and leaning into our expertise, it wasn't my role that moment to necessarily step in and help with that. But because I have the training expertise and the knowledge, it was not unusual for me to walk by and say, you know, ask the nurse, like, could you use some assistance with this? Or, how can I help? And a lot of times it was just kind of that basic expectation and education to the kiddo of what to expect, rather than telling them it's not going to hurt, because it probably will hurt, and really just kind of managing those expectations. And so that's the first thing that came into my mind, but I'm certain there are others.
Well, just to follow on that, Michaela, as I did put in the chat, we also have dental at Compass. And so I'm going to say one obvious and maybe one less obvious place where I've seen this come up. Certainly dental clinics. I think we all are pretty aware that dental anxiety and phobias are pretty significant. And in many FQHCs or integrated systems, there is dental care provided. So that's just something that's maybe, like I said, a little more obvious. One of them that was less obvious, I think, oh boy, sorry about that. As we kind of made this outline and preparation for this talk, is that some people still receive gynecological or pap smears at primary care and through their primary care. And so in my previous life as a BHC, there were a few instances of patients who had been traumatized in some way and needed the comfort and support of another person in the room directly kind of walking them through and talking them through that procedure.
I could echo things, but I'm curious, Justin and Letitia, if you guys have other things that you've experienced or would want to throw into the discussion.
Yeah, so just to introduce myself, I am a PhD candidate in counseling psych at Mizzou. So we're trying to get kind of get more involved with MOPA, so I'm excited to be here. This is my first meeting. But the first thing that came to mind for me was also actually dental care. I'm training at the Thompson Center this year, and we actually had a pediatric dentist come in a couple weeks ago for training on that, working with kiddos and adults with autism, given also kind of the sensory problems that they experience in those types of settings. So that was the first thing that came to mind for me. I can't think of any other experiences in my training so far that I've had relevant to that.
It's a great add-on with the specific population needs. I appreciate that point.
I would like to add in for individuals, some individuals won't check their insulin. And so that was something that became part of my diabetes treatment. So, and Michaela, what you were talking about earlier about some of these things in the clinics, right? It's not necessary. We don't read about this in the book. The manuals don't outline things like this because distressing things occur in the clinic that you can't predict. And I think a lot of times it does, like the eyes kind of go to the BHC. And of course, our ears perk up because if you hear somebody in distress, you immediately respond to that. And I think when you were talking about that, my thoughts were like how many crises in the clinic that have occurred that I've just like heard in another hallway and gone over to see if there was a way that I could help, or an individual, a staff member is in distress, or somebody in a patient room is being really loud and you say, can I go in? What can I do to help? And so some of these things, I think part of the draw to doing this particular roundtable was there are so many things that we do that aren't outlined in the books that we're not taught to do, but we have a skill set that just keeps extending. It is just this empathetic, understanding, de-escalation, relaxation skill set that we can use in so many different ways. And procedures are a great example of that. I also experienced a lot individuals who would, so the physician would give them an order to get blood drawn downstairs before they left. So it would be on a different wing or different hallway. It wasn't happening there in that exact clinic space. And those individuals just walked out the door. And that happened repeatedly. They just didn't go. And so I would start checking the charts to see, did they go get their blood draw after they were told to? And probably 20 to 30% of people just didn't go get it. And then I would call them, and the overwhelming majority was, I don't have time, which maybe, or I don't like getting my blood drawn. And so I've not done it for the last 4 years. Every time I come for a wellness exam, they ask me to go do blood draws, and I walk out everywhere. And nobody was ever noticing. So that's another piece I think that we can start making that part of our I don't know, the way that we function, if we start noticing these gaps in care where we have a skill set.
And I think too, just to, acknowledge that there is space for this work in traditional outpatient therapy. So, in counseling programs, you're probably not going to be a VHC, but you are going to interact with individuals who have health needs and who are not taking care of those health needs because of some of these anxieties. And so, I think it's something, you have a patient who has anxiety and they may not bring these concerns to you because it feels outside the scope of that work. But with the right questions, you can really find out, wow, they haven't been to the dentist in 20 years, or they haven't gotten their blood drawn, they walk out every time, or, they're a kiddo who can't get their flu shot because it's too traumatic, and there's a space for those things. So I think it is also about empowering everybody in behavioral health to ask the questions and feel like they have something to offer when they get the yeses to those questions. I think for me, oh, go ahead, Chelsea.
No, that was me. Go ahead though,
Oh,
Kristen. Ladies
Justin,
first.
yeah,
Always.
no, go ahead, Justin.
No, you started. You finish.
I was gonna shift gears. So if you wanna.
Well, what I was gonna just tap on is the idea of demystification. I think that's one of the biggest things that we could potentially, excuse me, no, bring to the table. I think that there's a lot of things that get built up in a very negative light, especially going to, say, the dentist or going to the doctors, just going to anybody. We all know of the horror stories, quote unquote, that churn the rumor mill, and I think that's one of the things that gets spun around frequently, especially with the young ones. I know they hear just how bad and how horrible a dental procedure is going to be, or getting their blood drawn is going to be, or even just getting their throat checked with a little stick on the tongue. I mean, there's all these little things that can come up. And I think part of it is helping not only on the relaxation side, but helping them walk through the processes of understanding that it's not as bad as what you think it's going to be. And as Chelsea even talked about, and Michaela a little bit as well, explaining that it is probably going to hurt an extent, but this is what it is. It's not that it's going to take your arm off. It's just going to sting. It's et cetera, et cetera. There are things that we can do that will help outline, that will, again, demystify, help structure, as well as give comfort and support. And then for the follow-up, we can even come back and say, like, no, how was it? How did that feel? And you can re-solidify, then they also become proponents of that acting change for those around them as well.
And I could have like an hour-long soapbox about needle pain in pediatrics, and I will save you from all of that because I have a lot of feelings about it. But I think overall, there is a general, there's a general sense that they're just kids, they won't remember it. They get the needle, they get the shot, and then it's over and we move on and we get our sticker and goldfish and everybody's good. And so let's just hold them down and do it. And especially in pediatric offices, my experience has been there's a lot of resistance to getting the BHC involved or taking these extra measures to minimize that experience of pain or that anxiety because it's time consuming. And vaccines are all day long in pediatrics, right? I mean, vaccines, blood draws, strep tests. I mean, this is just all day long. They don't have time for this. And so there is kind of this pushback around getting these other things involved. But it's important that we do, and it's important that those shifts in care happen. There is a strong body of research at this point that early experiences of pain, and most of this research is around NICU and neonates, but that early experiences of pain change your brain development, change the gray matter in your brain and also impact your experiences of pain as an older child and an adult. That can make you more, if you have negative pain experiences in early childhood, you have more acute pain in adulthood, more likeliness of having chronic pain, and more likelihood of having anxiety and fear about pain, all from pain that occurs before you'll remember it. So I think there's really this shift that needs to happen about recognizing pediatric pain as important and as developmentally meaningful. So there's a lot in that, but I think BHCs can have something to say about this to make sure that education is happening and to also make sure that we can offer solutions that work within the clinics. So they're, and I can talk about what some of those solutions are, but just to give an example, there's this thing, it's called the Buzzy Bee. And it is this device that has wonderful research around it. It's an ice pack, wings, it's very cute. And then it has a bee body in the front of it, and the bee vibrates. And the way this works is you put the ice pack on the arm or the leg or wherever it's going to go for like 5-6 minutes, whatever it is. That numbs the area. Then you turn on the buzzer, and then that like essentially further scrambles the senses. It's all based on the gate theory of pain, that if you have all of this sensation happening, you're not going to perceive the pain in the same way, and it's effective. So then you take off your buzzing frozen bee, you get the shot, everybody's good. But the problem is you have to have that thing in the freezer, and then you have to clean it, and it takes more time. It's just not practical. And so I think it is upon us to figure out, how do you help clinics identify the people that are going to have the most issues and be prepared for them? How do we find modifications of these? Maybe it's that you get like one of those tube frozen ice pops as your treat for the shot, and you slap that baby on your arm for 5 minutes before the shot, and then it's yours. I mean, there's just simple little things that I think we can take the research that we have and modify it to be effective in real life settings. And that's all I'm going to say, and I'm going to stop.
I would like to say that those Buzzy Bees are $50 a piece as well. So it's not like you can just, a lot of individuals can't just buy them to have them in their freezer, and then you got to remember to take them in. But they're also expensive, but they also come in extra large. So adults can also wear Buzzy Bees. But that reminded me, Kristen, when you were talking about pediatrics and shots and stuff, I forgot, in a past life, I worked in a pediatric clinic, and I was trying to do therapy in an exam room in a pediatric clinic, and it was constant screaming. This was the first time I had worked in primary care, and the screams, I was a new mom, that were coming out of the exam rooms were absolutely triggering tons of anxiety in me, and screaming for mom. Like, there was just so much about that was just difficult to do my job in anyway. But the screams, I forgot how much that bothered me. And when I found out that they were just holding children down to give them the shots, there wasn't a lot of interventions happening. They were holding them down to give them shots. They were also holding them down to give them strep tests. And no one asked, like, what it feels like for that child to be held down. So many children have trauma. Nobody asked, why is this bothersome that we take a strep test? Like, the lack of trauma-informed care that happens, I think, without them really understanding. Of course, they're doing the best thing that they can do as providers, but I think it's our job so much to help them have a more trauma-informed approach, because I don't think they think about trauma, not only the consequences of that action, but previous consequences and why children have a negative reaction to the things that they're doing to them.
Now, one of the things I can say to that too, Chelsea, and in fact, it's actually in response to something Kristen said as well. One of the big points on that is there's a misconception of that they're just going to forget, that there's a big principle that, well, they're small, they're young, we can put them through this traumatic event and they'll be fine. They'll bounce back. They're kids, they're hardy. They'll do this. And I think that's one of the biggest misconceptions. On top of that, it's also relegating the entirety of their experience to something that we think that is just going to be forgotten. And I guess from a negligence and almost abusatory type of standpoint, it's like, what is that actually doing? You know, are we inflicting more pain than not? Are we causing these things? Are we essentially setting these individuals up to fail, further in life because of cognitive dissonance? We have the cognitive breakdown. That the misplacement of the gray matter. It's like, as a cognitive of the group or cognitivist, I can't speak today. It's a big thing in my world, is understanding what type of neurological disruptions happen here, what type of counterfactual realities are now thus made. And if you have any hope, I guess, of having these individuals progress forward in a healthy manner, pushing anybody to a table to give them a shot, I mean, let's be honest, no one's going to be accepting of that. And then you put a child through that, it's unbelievably traumatic. I mean, then you have external versus internal dissonance mixed with environmental dissonance, and you have social. I mean, there's so many things that go wrong with that.
It's just painful to think about. And as adults, even, like, that would be so traumatizing. Individuals with developmental disabilities, that would be incredibly difficult. They don't understand what's going on. And then, of course, the next time it's time to go to the dentist or the doctor, there's a tantrum. And why are you being so difficult? Well, I don't know. I always feel so bad for dentists, because I think that dentists are just avoided like the plague. Poor things. The concept of inoculation theory has always stuck with me. No pun intended on that either. But basically, like, it's such a simple concept. Like, to your point, Kristen, like, it's a simple concept. It's not necessarily always thought of, or we don't necessarily create space for that, but it is. You tell people what to expect. And that way, whenever whatever happens is in line with those expectations, they are validated. That experience is validated. When you tell them it's fine or it's not going to hurt, that's invalidating. On top of the physical pain, we're developing a mistrust for the system at large, et cetera, et cetera. And so just pure inoculation theory alone, minus the $50 thing or whatever, that we know is really a very helpful tool. And so, of course, we know multimodal and integrated multiple kind of interventions are always best, but that's something that has always appealed to me. That's kind of something that can be straightforward and pretty simple, I think, for anybody to provide.
This is just a really quick note on this topic, and I'm sure I'll add more as we go. You mentioned kind of the trust in the system, and I think it's important to recognize the unique experiences of persons of color and other minorities in terms of even coming into any healthcare situation with a long history. I mean, was it maybe Justin that mentioned the horror stories? I can't quite remember. But these are genuine horror stories in many ways, in terms of how healthcare has been used against or dishonestly for people of marginalized populations. And so that comes to mind. And then, it kind of ties in for me to health literacy and lower socioeconomic status. And even in, the majority of individuals, research shows that most people don't understand the instructions that they're being given. Like, up to 60% of people mistake their prescription medications and can't really read a medication bottle appropriately. And so, again, soapboxing, I guess, to some extent, in terms of just wanting to be extra clear that we're going to have to work differently and uniquely with different populations, of course, but recognizing and validating that in some cases, this mistrust is really systemic. And, I did a kind of a informal survey of social media friends to, what procedures do you avoid? And a lot of them are things that we've already mentioned. And I had other individuals who didn't say this publicly, but who, direct messaged me and said, I don't even want to fill out the paperwork. I don't know how they're going to use my information. There's so many, they ask so many questions. It seems like too much to just go in and consent for treatment. You know, what else is going on here? That can sound like paranoia, but in the cultural context, it's a completely reasonable concern.
That reminds me also, so if you look at research on procedural anxiety, like the overwhelming majority of information that comes up is on pediatrics, right? So there's a lot, obviously, that those individuals don't have a real good coping skill set built yet for them. But when, as Kristen mentioned, these children that become adults who have trauma now from all of this terrible procedures that they've gone through, the process of it anyway. And so then they become adults and they do have a skill set of coping skills. Now they may not be great, but they do have ways that they cope. And so I think for adults, a huge piece of this is, and I think Justin hit on this, identifying what is it that helps you? What are your thoughts? What are your fears? How do we demystify this experience for you? Is it education? Is asking a lot of questions how you reduce your anxiety? Is fully preparing? And have we made that available to you? It's oftentimes not. They might Google it or WebMD it. All those things are terrifying. What have you used in the past? Have you used music? Have you used relaxation techniques, breathing techniques? What's the best skill set that you already have? And how can I tap into that to address this issue? Whereas kids were doing more teaching them how to do those things. But then we get to geriatrics, and that gets left off too. Nobody talks about that. And when I think about geriatric patients, so oftentimes, like even the way that information is explained to them, it's fast. And even just sitting, you have to sit in front of an individual. Individuals lose their sight as they age, a lot of individuals. So even sitting off to the side of somebody can reduce the ability to understand what's happening. Also, when you're doing a procedure, it's important to stand in front of an individual who's geriatric so that they can see you and speaking deliberately. All those things are important. And I think about all the little things that just get missed because we make assumptions. And then with older individuals, deciding whether or not to have a procedure, if it's a large procedure, that's a big question. Like we might bounce back from something, but they may not. And they have a lot more health complications. And so their anxiety might be death. And are we addressing that? Or their anxiety might be, do I have support post-operatively when I go home? How do we address that? But we know what we're not doing is we're not asking those questions. And so I think our role so much has to be on asking the questions and identifying anxiety where the medical system might not see it. Because they may say, especially with a geriatric person, that's just part of their presentation. The geriatric person may not know that they've had anxiety their entire life. And they may not know to say these things, but they might not show up for their next medical appointment. And that's going to be our big red flag.
Chelsea, on that point, I think one of the big things is to make sure that there's not any sense of the dismissiveness in terms of approach. And I think that's a big thing because, you know, we talk about social anxiety, we talk about procedural anxiety, we talk about all these different levels, and it's easy to take anxiety, relegate it to the side and say, oh, it's not that big of a deal. Or, you know, this person doesn't have it. They haven't exhibited, they haven't shown, they're not. And to take a presumptive stance that, well, then they must not. Now, we may be, you know, working with somebody or talking with somebody who's very, very good at hiding just how horrible they feel on the inside. I mean, if we think about that, you know, we as a people are really good at building unbelievable facades, and we bury things very deep. And in fact, it's typically those facades that end up, you know, becoming the most problematic situations. Those are the ones that we find at the last straw because they've managed to bury deep enough and hide it far enough that no one does see it. So I think it's one of those things just to be, you know, cognizant of the fact that there's a high probability that there is a level, even if it's minor, it does exist. And to exacerbate that by being dismissive, to ignore, to not acknowledge, you know, those are the things that we could do that are, I mean, even if it's an indirect response, we could be, you know, progressing that or feeding into that. And it just one of those things, as this type of you know, care progresses, we all and the community as a large needs to be more aware of, what can we do to try to minimize that particular impact or potential impact.
I love that perspective, Justin, and it makes me think of, the medical culture, behavioral health, just healthcare culture in general. Honestly, a lot of people don't know that they can ask questions, to their satisfaction, so to speak. White coat anxiety aside, a lot of people just kind of see providers as sort of a respected figure and feel like they need to take in information and really don't know that they are allowed to ask and aren't necessarily encouraged to ask. And some of the research really suggests that having nurses, behavioral health consultants, physician providers who are willing to talk to the client about their thoughts about the procedure can be very helpful, because again, you can then move into some of the demystification, the explanations, what to expect, etc., kind of inoculating them, Michaela, to what's to come. So I think just the healthcare culture in general can sometimes be like a top-down process where things are being kind of done to or at clients or patients without them realizing their own right to be empowered to participate and to make choices in undergoing procedures or how things are done. So I think I have more to say, but it'll come back around.
It's such an interesting thing that you just said, because I thought, what a simple thing that we can do is just to give people permission to take up space and to take up time. I recently had a surgery, and I had, I'll just own it. We were talking about like defense mechanisms and burying it deep kind of thing. And I'm just like, it's fine. So I had 2 discs replaced in my neck about a month ago. And so it's so interesting. I would have never dreamed. I'm in the healthcare field, BHC, yada, yada, right? I would have never dreamed about asking my provider, who was very good, highly recommended, but I wouldn't have dreamed of asking him anything more. He was always seemed like he was in such a hurry. And so it's like, I was like, I know these things, but I don't like know these things. And so it was like such a relief that he had a PA, and maybe that's why he didn't take a lot of time, but he had a PA that was so incredible. And he was like, literally, we'll sit here, we'll answer any questions you have. We'll talk it through. But it's interesting, someone mentioned something earlier, because I research everything. I'm a consumer report gal, that kind of thing. But I never thought about what happens after. Like, they made sure someone was there to drive me home from surgery. Like, there was no question of like, so can your cats maybe take care of their own stuff? Because like, you're not allowed to lift more than 5 pounds, and you're not allowed to do this. And it's like, okay, like, and I don't know, I guess, and in the background, of course, I was talking with friends and family, etc., like where that support would come from. But I literally said to them so many times, what happens to the poor people that don't have that? To the older population who don't have anybody nearby? Or to, maybe, again, developmentally disabled people or someone who only has a care provider that comes by once a week or something. And so just, that's a lot of just stuff. But when we think about like surgical, I fall into the same problem. I focus so much on like the before and preparing for the surgery, what happens after. And that is such a space that I'm not sure it gets a lot of attention per se. It's like, okay, we're done. We'll see you in, 2 weeks for your checkup, and then in 3 months. So just a very, I'm learning a lot in this moment about myself.
I always love your insights, Michaela, and I hope you're healing well. I'm thinking about how you're willing to put yourself out there and lean in and use your own experience. Part of what came into my mind, and I don't hear you saying this specifically, but I think it does come up too. We're talking about procedural anxiety, different kinds of anxiety. There is also the notion of really wanting to be a good patient, right? Like there's such a desire to please our providers. Again, we sort of see them as authority figures and as people to emulate and to respect. And so does it hurt? Well, is that going to make you stop? Because I don't want to interrupt your day if it hurts and I need an extra shot. I mean, just without even thinking about it, we're good. I'm good. I have no idea the words that just came out of your mouth, but that's on me for not being a doctor, right? And even, oh, sorry, go ahead, Chelsea.
I was going to say, one of the things that I was thinking about that also is a role for us is for individuals who are going to have like a surgery, and the individuals who smoke. Oftentimes that is a coping skill for anxiety. We know that. Anyway, so smoking, a lot of individuals need to stop smoking about 2 months before their procedure. But what I found is oftentimes there's not a discussion about that. Or if there is, it's like on a paper that's handed to them, like you should do this. So this is another thing that I think that we can have it be part of our job duty is if there's an individual who's going to undergo a procedure, who is a smoker, come get me. Let's have a discussion about this. Let's create a plan for this so that they have other tools to use, and also they'll have better post-surgical outcomes. Total tangent.
A nice crossover from last month's discussion. I dig it.
So I think we've talked about some of a lot of the problems. I do want to make sure we just hit on some practical solutions. So, a lot of this, we're using our same tools that we would use for addressing, like, what are your coping skills? How do you use good, like, imagery, deep breaths, progressive muscle relaxation, a lot of those things that are already in our toolbox. But there are some other things specific to pain, particularly specific to needle pain, but they can generalize beyond that, that are worth just knowing and having awareness of. So for pediatrics, for babies, sucking is a major natural pain relief. So you can get that a couple different ways. Breastfeeding is one that has sucking and also the oxytocin and hormones that come with nursing. There's also sucrose, which is sugar water, that is a natural analgesic for babies. And so you can give sugar water on a pacifier, and that's something any parent can do themselves. They can nurse before the shot, or they can offer a pacifier that's literally dipped in sugar water. Just bring a pacifier in a baggie of sugar water and offer that 5 minutes before the procedure, during and after it. You can nurse during a vaccine. Like, and you will get pushback. I can tell you from personal experience that that's not what is the norm. I had to get permission from the doctor. Like, it's silly, but you can, and you can advocate for those things. The other thing with older children, like toddlers up to kids, is what's called comfort holds. That essentially means put them in your lap because you, the caregiver, are comforting. So there's an element of skin to skin to it. And then just the oxytocin that comes with a hug, essentially. So logistically, the way to do it is you put the parent on the exam table, and then the child straddles, like sits face to face with you so that their thigh is exposed to do a shot. Or for an older child, you can even, sometimes there are reasons why laying down is the only thing that the clinic will allow, and or the thing the child needs. But then your mom and you are hugging, you're not holding down, you're like snuggling, right? Or your dad or whoever, but shifting how we look at positioning and how we involve the trusted caregiver in that. Psychologically, offers improvement, but also just from a genuine analgesic perspective, those comfort holds and things like sucking have effect, like proven research-based effect on being an analgesic response. And then the last thing is things like numbing creams. So lidocaine is an example. I mean, you can get that over the counter and you can bring it in and you can put it on the area ahead of the procedure, and that will offer numbing ahead of the shot. And so you have a lot of clinics that are maybe resistant to doing it themselves, but as a BHC or as a counselor in an outpatient setting, knowing that you have a family that struggles with that, you can offer that recommendation. There are a ton of great handouts online that you can find. There's a Canadian organization called It Doesn't Have to Hurt, and they have promotional videos. Canada's really good at this. So they have all kinds of promotional videos and also just fact sheets that you can print out and distribute. And then one that I'm just personally familiar with, but know their resources are available and good, is Children's Mercy Hospital out of Kansas City. They have what's called the Comfort Promise, which is an initiative that is health system wide. And it is this promise that we are going to, in every facility in this system, use these comfort measures. And they have handouts about needle pain and comfort holds and sucrose and recommended dosage and timing for lidocaine and sucrose and all of that. So from a pediatric perspective, those are some things that you as a they don't require prescription, don't require special permission. You can work with the clinics or with families themselves to advocate and ask for those things. And there's lots and lots of information available online.
So helpful. Like I didn't know about some of those things. And so that's so incredibly helpful. And it got me thinking too about, you were talking about like parents being prepared and like bringing things with them in preparation for, we held a couple of vaccine clinics, which many organizations did during the pandemic, especially, when vaccines weren't readily available or were not readily able to be administered. And I volunteered for one of those, and it like never dawned on me. Again, I'm like learning a lot about myself. It never dawned on me to like prep for people who were like gonna be needle averse or like vaccine averse or like worried about whatever. And so there were several though during that day that would come. And so even if you're not prepared and you're just like winging it, as clearly I was that day, I just said, like, a couple of people, they sat down and you can tell they're like nervous, they're fidgeting, they're asking a bunch of questions like, is this gonna hurt? Or someone just outright just say, I'm really nervous, I hate needles, this is terrible. And what I would just say is like, oh my gosh, like you totally came to the right table. I'm here to help. I'm a psychologist by training. That's just a really fancy word for saying I'm just gonna work you through this. And so I literally, all I did was like talk to them about like their purse, or like, have you seen, like, I noticed you have a book with you today. Like, tell me about that book. What's going on with that? It was like the simple distraction that, exactly, Robin, like just distraction of getting them through that moment. So I guess all that to say, like, oh yeah, absolutely. Like preparation is the name of the game. And by all means, totally, we should do that whenever possible. And at minimum, I think distraction is a very useful tool. Deep breathing, like just different things that we know that we can carry in our toolbox. They're like they were within us all along, kind of thought. So,
well, I think along that, I'm sorry, Chelsea, this will be quick. With what you're saying, Michaela, in terms of utilizing distraction, I think the other piece of what you were doing there, whether intentional or not, is normalizing, right? So anxiety builds as we feel like we shouldn't be anxious, or whatever kind of cognitive tricks we're doing to ourselves to say that it's not okay to feel nervous or anxious, when in fact, as we've heard, most people feel at least some level of anxiety in many medical healthcare situations. So normalizing that can go a very long way.
Well, and Robin, that was perfect, because that's part of what I was going to say. So as Michaela was talking, I was jotting down, like, what are the things that we can just do really easily in our practice to address this in adults? And one is something Robin hit on earlier, which is serving as a support for them. You gave an example when we had talked previously about how sometimes individuals are alone and they just would like some support. And I think so often in mental health, we are told to shy away from these things where we almost serve, it's almost like a dual relationship. But in the medical system, we have a lot more flexibility and there's some beauty in that. And some of that is that we can just be a friend in those moments and a support that they didn't have coming in with them. That's huge. Education, that demystification that Justin hit on, we can ask what questions they have, even if the provider's already left the room, and we can find out that information for them, or ask the provider to come in and answer these questions for them. Cognitive exposure was something I wrote down. I was thinking, I've had people go through what it would be like to go down and actually get their blood drawn after they left their appointment. Like, let's imagine that happening. And then let's walk down and look at the chair. Let's look at the space. And so some of that exposure therapy can be really helpful. Noticing those red flags, walking out of the office instead of getting their blood drawn. They haven't been in for 2 years for a wellness visit, or they didn't show up for their pap smear. Checking in on those things when we notice those red flags that might be seen as just non-compliance. Ask questions of the provider when the patient's in the room. So if you know that this is a question that you have after you just heard this, ask it. And then that alleviates that burden off the patient to have to ask those questions. Check in on patients with pre-existing anxiety disorders, as we know they're more predisposed to struggle with this. So if you know that they're going to have something, maybe it's very minor, but just ask the questions of how are you doing with this, because we know that they're going to be more anxious probably than the average individual. And then I had down normalizing procedural anxiety with both the patients and with the medical staff. And something that we had talked about previously as well is we are in a unique position where we are not desensitized to how scary some of this stuff is. Like it's scary to us. Individuals who do procedures every day and give shots and all this stuff, they get really desensitized to just thinking that this is not scary. They can't really imagine anymore how it felt maybe the first time. And I think it's just individuals who actually don't do the procedures, who are just kind of a bystander. We have a lot less desensitization to how scary that can be. And it gives us a great lens to be able to ask really great questions and provide support and empathy to patients as they experience it. We have 10 minutes left. What questions, thoughts, feelings? This was kind of like an emotionally charged roundtable that I was not expecting. I don't know if everybody else is feeling that, but ready to go like punch a elephant or something. I don't know.
Leave the pachyderms alone. One thing you didn't mention, who am I talking over? Kristen, go ahead.
Go for it, Robin.
I was just thinking of modeling, whether through statements, whether through behaviors, as Kristen was talking earlier, I was thinking we need to get all new parents into a parent group and teach them about their emotional response and how that translates and how their kiddos are picking up on it. So how do they keep themselves calm? And jumping back to a young one, a 3-year-old that I worked with that had juvenile rheumatoid arthritis and had to get multiple shots in the clinic each week, clearly hated it, and worked with her for 2 years with medical supplies, obviously not the needle, but the syringes, the tape, the gauze, a Care Bear, where I would talk out loud, oh boy, I'm scared, Care Bear is scared, and voice, this things like this is going to hurt. However, it will, I didn't say however to the 3-year-old, but it will be over soon, right? And then having the parent hear me and also come in and do that, and then ultimately passing the Care Bear to the child over time to be the one who initiates the treatment. And so I'm saying a lot of just stuff.
But Robin, that's exactly the type of thing I was going to add, is how do we help support people, whether it's a parent or an adult partner of somebody who has anxiety, or caregiver for a geriatric patient. We all have people in our life that are giving us feedback about these things. And how do we help whoever those support people are be matter of fact? Because the patient has enough emotion invested in this they don't need more, right? So how do we, and I'll use parents because that's or kids because that's my zone, but this applies, I think, broadly. But how do we coach parents to not treat this like it's no big deal, it's not going to hurt, it's nothing, and lie, but not go too far the other way and say like, oh, I know it hurts. You're so brave, honey. I'm so proud of you. I know it's awful and it hurts and I hate it too, but you're so brave. And we're going to go to, Steak and Shake afterwards and get a milkshake because it's going to hurt. And I really want, instead, I'm going to get you from school a little early today so we can do your checkup. There's going to be a shot this year. Do you remember last year? Do you have any questions about that? Yeah, it hurts. I'm so grateful we have those. It protects you and it hurts. I know that part stinks. I would love to just make since I'm getting you early, let's make a mom date out of it. And do you want to go like get ice cream or something afterwards? It's not because it's so painful and I need to help you feel better. It's just you're pairing a nice thing with this other thing. And I know that's subtle and it's hard to communicate to families how to do that. But how do you just make this a thing that you do? And then you maybe pair something positive with it, but it's not because you need to do this fun thing because they had this miserable experience that you need to save them from. That's
Totally.
a lot. That's not a very scientific
No.
presentation, but it's that presentation matters so much.
Yes, I love that. And like the practical like administrator in my mind is like, and when would that happen? And so like that's part of it too, is like kind of what you said, Robin, like we gotta create a parenting group, like we gotta make sure parents and everyone knows what to do, because it's like those checkups typically happen once a year. It's easy to forget that stuff. It's like, crap, so-and-so's appointment is later today. That's what I would imagine a lot of parents' lives are like. It's like child number 3 is today. And so like just thinking about like creating space for preparing parents for those things and making sure they go into those spaces prepared, because the checkup will happen every year. And so what do you do next time? Maybe this year was a total wreck. So like, how do we like make sure? And so maybe that's part of, and I'm kind of just, it's more rhetorical really. Certainly if there's an answer to that, I'd love to hear it, but like, that's hard to create space for too, and it's infrequent.
And here's what I can tell you just from personal experience. When you schedule those visits or you get reminders about those visits, I often will hear, and there's a vaccine at this appointment. And even that, could be, this is just me being really optimistic and dreaming. But even that could be an opportunity for that front staff to say, there's a vaccine at that appointment. If you need any help preparing your child for that, let me know and I can get you connected to somebody that can help with that. I mean, that would probably be like looked at as like, that's too much, but that's a simple thing that could really go a long way.
Words matter. You're talking about subtle changes, but like that, those are huge changes. They look subtle on the outside. Those are awesome, Kristen. Any other?
Fully integrated care really does start the moment the client or patient walks through the door. So, we have some wonderful, we call them customer relations specialists, I believe, front desk staff, because they do so much more than just kind of check people in. And I think, that would be completely reasonable in terms of a fully integrated perspective. It doesn't seem too pie in the sky to me.
My brain always goes to adults too, but when you were talking about that, Kristen, my thought was, or do we also check on the parents? Because if they have some anxiety about the child getting it, can we address that with the parents too? And I think we get real hyper-focused sometimes and forget the people that are in the room with them. And that energy translates. It's like words matter, but also does the energy in the room, which is exactly what you were talking about, that hyped up response.
Yes, and it's so common. Yeah. I mean, I'm going to spare you all entirely different soapbox, but you think about vaccine hesitancy and how much is pain, I mean, vaccine injury, pain, I shouldn't use my air quotes, I'm sorry. But pain is part of what gets lumped under vaccine injury. And how do we educate that pain is part of this? Pain is part of this. That is normal. And that is a small cost for the protection this offers. How do we normalize that there is pain in healthcare, and that pain has a purpose, and that is going to offer you protection? You know, so something we talked about when we prepared for this, but this whole pain is the fifth vital sign and pain must be avoided at all costs has really led us to lots of negative outcomes in healthcare, one of which being the opioid epidemic. Pain does not have to be avoided. Pain can be prepared for and experienced as part of something that can lead to benefits. And so how do we help people be rational and understand that, and just have this cost benefit approach that yes, this vaccine pain is real and it's going to happen, and it is part of this pro con that ultimately I believe is worthwhile.
If I knew how to do praise hands right now, like Robin keeps doing all the thing, I don't know how to do that, but Robin's going to show me, but that's what I think about that. So the last minute, Michaela said it's like when you start a workout regimen, like absolutely. And then Justin said it's the ROI of the process. So great place to end, actually. And I just want to remind everybody that the views here today are our own and do not necessarily represent the views of MOPA. You can check out all past roundtables at the Learning Center on mopa.org. There are CE opportunities there. And then we will see you next month on the first Thursday. Thank you guys for being here.
So great to see everyone. Take care.
Bye, Robin.
Bye.